Hello everyone, I'm here to talk about the topic enhanced recovery after cardiac surgery. So most of my lecture is from these two papers. One paper we have they told about the guidelines, various guidelines, and then there was a first update regarding that. So most of my lectures are from these two articles. So basically, what is enhanced recovery after surgery? It's a multimodal transdisciplinary care improvement initiative to reduce complications and promote an earlier return to the normal activities. So it was initially started in 1990s for patients receiving colorectal care, but now it is practiced in more fields of surgery. So what are the various goals? One is improvement in the patient satisfaction, reduce post-operative mortality and morbidity, reduce length of stays, and reduce RBC transfusions. So how was this ERAS of cardiac design? It is the ERAS Cardiac Society, former collaborative agreement with the ERAS Society, had a meeting where the group agreed on 22 potential interventions based on the literature search. A minimum of 75 agreement on the class and the level was required for the consensus. So basically the various pre-operative aspects were patient engagement tools. Patient education and counseling prior to surgery can be completed in person or through printed material or through novel online or application based approaches. So pilot studies in cardiac surgery have demonstrated the effectiveness of e-health platforms without any evidence of harm. So it is class 2A level C recommendation. So prehabilitation. So it is the most important aspect of ERAS. So where studies have shown that successfully demonstrated that a benefit of 3 to 4 weeks prior prehabilitation in the context of ERAS as a class 2A recommendation. So the various aspects were frailty assessment, refer to specialists, nutritional and anemia optimization, healthy living center referral, exercise and respiratory training. Next, coming to the preoperative correction of nutritional deficiency. The patients who are malnourished, oral nutritional supplementation has the greatest effect if started 7 to 10 days preoperatively. But currently, there are no adequately powered trials of nutritional therapy initiated early in the patients undergoing cardiac surgery who are considered as high risk. In addition, this may not be feasible in patients undergoing urgent or emergent surgeries. So it is given as class 2A level C recommendation. Preoperative measurement of HbA1c. The optimal control defined by HbA1c level less than 6.5 has been associated with a decrease in deep sternal wound infections, ischemic events and many other complications. So meta-analysis recommended the screening all patients for diabetes preoperatively and intervening to the levels of less than 7% as a class 2A level C recommendation. Preoperative measures of measurement of albumin for risk stratification. Hypoalbuminemia increase the risk of morbidity and mortality post-operatively. It is independent of BMI. It is a prognosticator of preoperative risk correlating with increased length of time on ventilator, AKI, infection, longer length of stay and mortality. So this was given as a class 2A level C recommendation. Then coming to smoking and alcohol consumption, both are associated with respiratory, wound bleeding, healing, bleeding, metabolic and infectious complications. Given the low risk of this intervention, a screening using validated tools and consumption should be stopped at least 4 weeks before the elective surgery. It may not be feasible in urgent or emergency surgery, so it is given as a class 1 level C recommendation. So consumption of clear liquids before general anesthesia, most of us mandate a 6 to 8 hours NBM for solid before an elective cardiac surgery, but RCTs have demonstrated, however, that non-alcoholic clear fluids can be safely given up to 2 hours before the induction. So cardiac surgery patients have these aspects like delayed gastric emptying owing to its comorbidities like diabetes mellitus. Even TE may also increase their aspirations, but this all has been kept in mind. So it is given as class 2B level C recommendation. Pre-operative carbohydrate loading. A carbohydrate drink is found to reduce insulin resistance, tissue glycosylation, improves post-operative glucose control, enhance return of gut functions, and no incidents of aspiration were reported. So a carbohydrate loading reduce the post-operative insulin resistance and hospital length of stay. So ideally at around in an average adult patient, it is recommended around 400 to 800 ml of this carbohydrate drink 2 hours prior to surgery is recommended. So it is class 2B level C recommendation. Then surgical site infection, deep sternal wound infection ranges with an incidence of around 0.8 to 6%. It is associated with various bad post-operative outcomes. Various patient factors and surgical factors are involved in this surgical site infection. So these are the recommendations. Class 1 recommendation: perform topical intranasal decolonization prior to surgery, ideally at least 5 days prior to surgery. Administration of intravenous antiprophylactic antibiotic at least 30 to 60 minutes prior to surgery, and clipping as opposed to shaving immediately prior to surgery as are under class 1. And class 2B, using the chlorhexidine alcohol based solution for skin preparation before surgery, ideally at least 3 washes before surgery over a period of 48 to 72 hours, and then removing operative wound dressing after 48 hours. So all these were recommendations. So perioperative glycemic control, multiple RCTs support intensive perioperative glucose control. Epidural analgesia also has shown to reduce the hyperglycemia incidence. After cardiac surgery, hyperglycemia morbidity is multifactorial and is attributed to glucose toxicity, increased oxidative stress, prothrombic effects, and inflammation. So this control has been given class 1B recommendation. So insulin infusion to keep a control of around 160 to 180 may be associated with improved outcomes. However, more high quality cardiac surgery specific studies are needed. So it is given as class 2A level B recommendation. Tranexamic acid or epsilon aminocaproic acid has been studied in various RCTs. So dosage up to 100 mg/kg on pump has been used. So it is recommended as class 1 level A recommendation. Hyperthermia, rewarming on cardiopulmonary bypass, hyperthermia more than 37 is associated with cognitive defects, infection, and renal dysfunction. Post-operative hyperthermia within 24 hours after even CABG has shown to be associated with cognitive dysfunction at 4 to 6 weeks. So avoiding hyperthermia while rewarming on CPB is as class 3B recommendation. So rigid sternal fixation. So wiring achieves approximation and compression but does not eliminate side-by-side movement. So thus which is an advantage of this rigid sternal fixation. RCTs have been done and they definitely showed better sternal healing, fewer sternal complications, and no additional cost compared to wiring at 6 months after surgery. So it should be considered in individuals with high risk like high BMI, previous chest wall radiation, severe COPD, and steroid use as level class 2A level B recommendation. So goal directed fluid therapy, quantified goals including in the intraoperative period include blood pressure, cardiac index, systemic venous oxygen saturation, urine output. Additionally, oxygen depth, consumption, lactate levels may augment the therapeutic tactics. So trials demonstrated reduced complication rates and length of stay in surgery specific to cardiac surgery. So it is as class 1B recommendation. So pain management, this is coming up in a very big way. Multimodal opioid sparing approaches can adequately address pain through additive or synergistic effects of different types of analgesics, permitting lower opioid dose in population receiving cardiac surgery. It is as class 1B recommendation. So this is the various armamentarium we have got right from the pre-op clinic to the discharge. This includes the general measures, the various analgesics like acetaminophen, gabapentinoids, NSAIDs, even the local anesthetics under like lignocaine infusion, and various regional like neuraxial, paravertebral block, and facial nerve blocks, and adjuncts like ketamine infusion, dexmedetomidine infusion. So these are the things which we got to deal with the various phases during the surgeries. So as we discussed, facial plane blocks, especially ultrasound guided, is coming up in a very big way with very minimal complications, and even the cryoanalgesia is also used in very minimally invasive surgeries and all. So all these aspects are done as a methods to like as a opioid sparing methods. So post-operative systemic delirium screening, delirium is known to occur in at least 50% of the patients after cardiac surgery. So early delirium detection is essential and appropriate treatment strategies important. So there are many non-pharmacological strategies which are used as a first line component, and then pharmacological prevention has like haloperidol and ketamine definitely didn't show great benefits in large scale trials. Encouraging data are emerging regarding the use of alpha 2 agonists like dexmedetomidine, like various screening tools like CAM ICU scores and intensive care unit delirium screening checklist should be used. It is recommended to do a delirium screening at least once per nursing shift to identify the patients at risk and facilitate implementation of the prevention and the treatment protocol. This is recommended. This is given as a class 1 level B recommendation. Persistent hypothermia in the post-operative period, that is to return to the normal temperature within 5 hours after ICU admission. So it is associated with increased bleeding, infection, prolonged stays and death. So it is recommended to prevent hypothermia using forced air blankets, raising the ambient room temperature, warm irrigations and IV fluids. So it is also given as a class 1 level B recommendation. Chest tube patency. Retained blood products can cause tamponade or hemothorax. It can also induce an oxidative inflammatory process, effusions, and it can also trigger. It is known to trigger AF. So this can be safe. The recommendations were for maintenance of chest tube patency without breaking the sterile field is recommended as class 1 level B, and stripping or breaking the sterile field of chest tube is not at all recommended, and it is as class 3A B level B recommendation. Chemical thromboprophylaxis, vascular thrombotic events like DVT, pulmonary embolism play potential complications after cardiac surgery. A recent meta-analysis showed that chemical prophylaxis could reduce the vascular thrombotic events without increasing the risk of bleeding or tamponade. So it is recommended as class 2A level C. Extubation strategies. So all these extubation fast tracking or this eras have been focused on extubation, early extubation. So early extubation within 6 hours of ICU arrival can be achieved with time directed extubation protocols and low dose opioid anesthesia. So it is given as a class 2A level B. So kidney stress and acute kidney injury. AKI complicates 22 to 36% after cardiac surgery, known to double the hospital cost. So there are new biomarkers in the picture where they can detect as early as 1 hour after CPB who are the patients at risk. So intervention algorithm like avoiding nephrotoxic agents, discontinuing ACs, ARBs for 48 hours, close monitoring of creat and urine output, avoiding hyperglycemia, contrast agents, and close monitoring of volume status and hemodynamic parameters play a very crucial role. So this is given as a class 2A level B recommendation. So apart from that, there are few recent studies they upgraded few other eras elements like control treat the preoperative anemia, goal directed perfusion strategies, comprehensive protective lung ventilation strategies, early post-operative enteral feed and mobilization after surgeries. So these are all these were also emphasized in the latest trials. So now this eras has extended within our cardiac surgeries into you can see into the minimally invasive cardiac surgeries, even into the congenital cardiac surgeries, and even into the durable VATs. So all this is coming up. So conclusion, although ERAS is relatively new to cardiac surgery, we anticipate that programs can benefit from these recommendations as they develop protocols to decrease unnecessary variations and improve quality, safety and value for the patient. A successful introduction of ERAS protocol is possible, but a broad-based multidisciplinary approach program is imperative for its success. So whenever we are talking about all these aspects, everyone thinks that there's a cost involved in all this, implementing all these strategies. But if you see, the value-based care is coming up, where the cost, the total cost at the time of discharge, or the total cost till the next follow-up is considered as the amount which the person is spending. So if you consider that, I think these protocols will play a crucial role in reducing the cost. So it's a multidisciplinary approach. So let's let us think about this and implement in our routine day practice. Thank you.